Thank you so much. Good afternoon. Thank you for coming to Tuesday Topics today. And today we're going to really talk about using the gap and the base to use them effectively to have a really clear, hopefully great understanding about your patient's perfusion, what you should do, how they should get better. And I talk a lot about a base deficit. So right now, I'm just going to give you this blood gas. I'm asking this rhetorically, but as you are attending, you can see your pH is 7.4, PCO2 is 40, bicarb is 24. Not really looking at oxygenation here. We're just talking about acid and base. And here is our patient. His pH is 7.32, CO2 is 28, and bicarb is 14. Now, if I was to give you a gap, I'm just going to make the gap up. This patient's gap is 11. And this patient's gap is 21. That's going to be really important. It's really important to pull in that gap measure from your chemistry, to look at the bicarb measure on your chemistry. And if all you have is chemistry, it can lend itself to tell you what else you might need to do. Now, this patient, of course, has significant metabolic acidosis. And remember, I said his gap was 22. So he's got a very wide anion gap and a very low bicarb. Now, if we were translating that for the grade E hospital, we look at bicarb on your chemistry. That is reflected as serum CO2. But on our blood gas, we don't give bicarb, we give base. So this patient right here has a low bicarb, a base deficit of around -9, and an anion gap of 22. Profound and significant metabolic acidosis. So what it's all about, when we talk about gap and we talk about base and what it's all about, why it's so important, it's important to remember that we're really reflecting on the balance between acid and their component, their partners, which buffer the acids. And those are bases. So any compound like ketosis, like lactic acid, any compound which forms hydrogen ion, which is the metabolic acid, and that hydrogen ion donates protons. So really, really important for us to appreciate that when we're talking about acids. And when we talk about base, it's anything that will actually attract a hydrogen ion and neutralize it. That's what bicarbonate does, HCO3. Bicarb accepts a hydrogen ion. That converts it into an acid, carbonic acid, H2CO3, which then when presented to the lung, you blow off as CO2. So it's important to understand the physiology of acid and base. The acid is hydrogen ion. Anything that donates it is an acid. Anything that binds it is a base or a buffer. Really important for us in terms of basic understanding. Now, we talk about that normally by talking about positive and negative charges, cations and anions, positively charged and negatively charged molecules. And these all will ultimately affect the pH. It's really important to look at these as, you can talk about them as electrolytes, you talk about them as neutralizers, and they can all affect the pH. The primary cations that we use when we're talking about anion gap would be sodium and potassium. Those are positively charged. And remember, the hidden one that we don't measure is hydrogen ion. It affects us, but we just don't see it because we don't measure it. And the anions are primarily bicarb and chloride. So that is a really important concept. And remember, ultimately, it's all about how it affects the pH directionally. High acid, pH goes down. Low acid, pH goes up. High acid, pH goes down. Low acid, pH goes up. So we just take a quick look at the cations. And again, remember the ones that we really focus on, that we measure, that we use in an anion gap calculation is sodium and potassium. There are other cations, calcium, magnesium, but remember the unseen one that has significant effect is hydrogen ions. So these are cations. They all have positive charge. And these are some of the anions, and they all have a negative charge, right? So bicarbonate is HCO3, phosphorus, PO4, chloride, and albumin. These are all anions. These all accept hydrogen, and these all actually facilitate or donate hydrogen. So those ions broken into positively charged or negatively charged electrolytes, it is really important to remember that to be in homeostasis, positively charged particles must equal negatively charged particles. So if I have 150 positive charged particles, I must have 150 negatively charged particles. That's what gives us a balance. But we don't measure all of the negatives or make accommodations for them. So what we say is normal physiology, the expectation is that there will be a difference between measured positives using sodium and potassium and measured negatives using chloride and bicarb. And that normal difference between the two is what we call a gap. And that gap is 12 plus or minus 2. So actually 10 to 14. Anything greater than 14 means that your negatives are down, and your negatives are down because the unseen positive hydrogen ion is up. That's what gives us our anion gap. So I love this slide. I wish I developed it. I didn't. It was from a colleague who did a beautiful acid-base presentation, just to remind us that metabolic acidosis is evaluated by determining the anion decrease. That means the negatively charged particles going down, and that's associated with an increase in the cation hydrogen. And the only way we can truly look at this is by looking at the gap. The problem is that whenever you have metabolic acidosis, you could have an anion gap, or you might not have a gap, and you might not have a gap because you actually have too much sodium chloride or too much chloride. So one of the things that has driven our transition from using 0.9 normal saline, of course that's sodium chloride, as our major resuscitation fuel is because that increases the presence of chloride. Chloride accepts hydrogen, translating that into a strong acid, HCl, and means that the gap is the normal, 10 plus or minus 2, but you have profound metabolic acidosis. So I want to remind you, whenever you look at a chemistry, your chemistry comes back, look at the anion gap, and look at the bicarb, and look at the chloride. So at Grady, you'd be looking at anion gap, total serum CO2, which is bicarb, and chloride. I can have a normal gap with a really low bicarb and a high chloride. You still have metabolic acidosis, but your gap won't reflect it because of the presence of chloride. So when we calculate that anion gap, most of us just throw potassium out. We're not too worried about it. Mostly we say sodium minus bicarb, which is negative, and chloride, which is negative. Sodium representing the positives, bicarb and chloride representing the negative. Normal is plus or minus 2. Now, if what's happened is I've given the patient a lot of sodium chloride, my chloride level goes up, my patient is acidotic plus hyperchloremia actually forces wasting a bicarb, my bicarb is down, but the gap is normal, even though the patient is severely acidotic. And they are acidotic. It's just an acidosis you gave them because of the hyperchloremia. So that's why most of us don't use chloride anymore. Used to also be that when we talked about acid-base balance and a wide anion gap, there was a mnemonic people used called mud piles. You can see it listed here. That's been replaced by a better mnemonic, which looks really more at categories rather than specifics. Glycols, oxoprolanes, lactic acidosis L, lactic acidosis D, methanol, aspirin, renal failure, and ketosis. Okay, so big list. Don't have to memorize it. No one's testing you. Nobody is worried about whether or not you know this, quite honestly. I just want to remember, I want you to remember, in ICU, when you have a wide gap, there are 4 primary reasons. I'm sorry. When you have a wide gap, there are 3 primary reasons: acute kidney injury, DKA, lactic acidosis. The 4th occurrence that can cause acidosis but doesn't present you with a wide gap is hyperchloremia. So if you're still using aggressive sodium chloride in resuscitation, always rethink that. Not saying one thing is better than another, but it will give you hyperchloremia, which will worsen your acidosis. And by the way, you were chasing your acidosis to begin with by giving fluid resuscitation, but now it's gotten worse. And that's typically what happens with sodium chloride resuscitation if you're giving more than a liter and you're doing it relatively rapidly. That's why now most of us do lactated ringers or we use plasma light. And sodium chloride is fine for the first liter, maybe the first 2 liters, but after that, we have to think about something else because we don't want to cause hypochloremic metabolic acidosis. Okay, so when we evaluate our blood gas scores, very, very, very important for us to, number one, make a determination. So here you can see my patient's oxygen, which is 212, and that's always measured in direct relationship to the amount of oxygen the patient is getting. That's for another talk. We're not talking about that today. Okay, that's known as the P to F ratio. And also we need to think about the amount of PEEP that we might be using. So I'm just going to say pretty much, even if my patient's on 100% FiO2, they're relatively well oxygenated. I'm not worried about that. I'm looking at their PCO2, their bicarb, and their pH. And I want to remember and remind when we're looking at this, importantly, when we're looking at this, we're going to make a decision by pH direction. pH is down. pH is down. And that's on the acid side. I'm blowing off CO2. That means I don't have respiratory acidosis. I have respiratory alkalosis, which cannot be the cause of the problem. My bicarb is down. And when bicarb is down, metabolic acid is always up. When base is in deficit, metabolic acid is always up. So I want to remember that and be really prepared for that when I'm taking a look at my patient. I really want to be aware. Okay. Now, we're not covering every single thing that's in their chemistry, but here's what I want you to see. Here's your sodium, and here's your chloride. So you have some mild increase in your chloride. Normal chloride is typically 92 to 100, anything greater than 100, depending on your lab might say 102, but your patient has a chloride level of 110. So this is of some concern to us because we're looking at our patient's bicarb, it's 8 in the arterial bed, 8 in the venous bed. Okay, our creatinine is 2.2, our BUN is 46, our glucose is 88, our sodium 142, and our potassium 5.4. So we can certainly say here, you have a profound metabolic acidosis, attempting to compensate by blowing off CO2, not able to fully compensate. And you have a pH now that actually is going to create a situation where your patient can't respond to vasopressors, where he's lost his vascular tone, where he continues to be hypotensive. You're looking at this and saying, what am I going to do? Well, first of all, stop giving sodium chloride. You need to get that chloride level down. Second of all, this is actually could be life-threatening, right? Because your patient is profoundly hypotensive. They're on 20 of norepi, they're on 8 of epinephrine, they're on vasopressin, and you can't get their blood pressure up. So you've got to really think about what is the cause here. It's not hyperglycemia, so probably, although not assuredly, not ketosis. Do have some high chloride, but that's probably not enough to create the acidosis that I'm seeing here. I do have a relatively wide gap. So remember, the gap is sodium 142 minus bicarb plus chloride. So 142 minus 118. I have a gap of around somewhere around 30. I can't do the math in my head. Isn't that terrible? So 142 minus 110 leaves me with 32, 32 minus 8. Sorry. So yes, so somewhere around 26. It's a wide gap. I have a wide gap. I have a wide anion gap. I have profound, severe, significant metabolic acidosis. And now I've got to figure out why. And remember, in the ICU, my first question is ketosis. My next question is AKI. Got a little elevation of my creatinine. So got a little AKI, probably not enough, again, to cause this profound acidosis, although we can't be sure. And most likely I have lactic acidosis from hypoperfusion. Now that hypoperfusion is also causing a problem for my kidney. I can see that because the BUN is up, the creatinine is up, and it looks like I may actually be generating a more significant acute renal failure. Now, this is what your provider goes through, but your provider can't look at this if we're not making sure they have this information. And our concern is, I have a patient who is breathing hard, he's breathing fast, he's breathing deeply, compensating here for metabolic acidosis. Don't think it's DKA, probably isn't fully AKI, although it might be a little bit, isn't fully from hyperchloremia. So now I need a lactic acid level to make sure that this isn't all hypoperfusion induced. blood gases and anion gaps. So I got a wide gap, I got a low bicarb, I have a base deficit. My bicarb's low, I'm always in base deficit, always. You don't have to have it calculated for you. Bicarb is low, you've got a base deficit. You got a base deficit, you always have an acid excess. If your acid, metabolic acid, is in excess, your pH will always go down. Metabolic acid up, pH down. I have to do something, and I have to do it quickly. I'm going to evaluate the patient. Is he ketotic? Is it AKI? Is it hyperchloremia? Does he have lactic acidosis and hypoperfusion? And what am I going to do next? Because this is what should be driving my therapy and my intervention, not just mean arterial pressure, but the presence of a base deficit, low bicarb, wide anion gap, all together now, all together, looking at that information, which really drives what I'm going to do. So I want to remind you about pH. pH is a negative logarithm of hydrogen ion. What does that mean? It means it goes in the opposite direction of the presence of hydrogen ion. Now, hydrogen ion is an ion donor, and hydrogen ion is a metabolic acid. As hydrogen ion goes up, the more I have hydrogen ion, the more my pH goes down. That's all. Base is a hydrogen ion acceptor. The more my base goes up, the more my pH goes up, because the higher the base, the less free metabolic acid I have. Base in deficit, metabolic acid in excess, pH down. Base in excess, metabolic acid is low, pH goes up. pH, I like to say pH is not correct, but pH, the presence of hydrogen. The higher the hydrogen, the lower the pH. The higher the presence of hydrogen, the lower the pH. So if I say the pH is 6.8, is this patient sick? Yes. Do we know why? No, we have to rule out his disease, because it's always the disease that causes your pH to drop, the disease that promotes the production of your hydrogen ion. Hydrogen ion is, in terms of presence or absence, is incredibly and profoundly important. And quite honestly, pH is never what I consider to be the most important. Once your pH drops, that's going to be really important, because it's going to reflect the state of the vasculature and the myocardium. But much more important is what caused your pH to go down. So I get a blood gas, I see the pH is down. I now am looking for it. Am I retaining CO2, which is acid? Or am I consuming my buffer, which means an increase in metabolic acid? So I work exactly with what I have on a blood gas, with one small part in my mind, which is bicarb down, base in deficit, metabolic acid up. That's all. It's so straightforward. And that disease is important, because I cannot take care of that patient or treat their acid-base disturbance without understanding what the disease process is. So first, just a basic chemistry, and hopefully same time or maybe later, I get a blood gas, because my chemistry told me bicarb is down, gap is wide. Or bicarb is down, gap is normal, chloride is high. In either case, I'm going to get a blood gas. I already know the answer, but I'm going to get a blood gas. And I'm going to look for three things: bicarb down, base in deficit, wide gap, all of which confirm significant metabolic acidosis. Then I have to determine the cause. And the four big causes, right, of metabolic acidosis: one, that doesn't widen the gap. So let's talk about the first three. In ICU, the three most common causes: base deficit, down bicarb, wide gap. AKI, DKA, lactic acidosis. High chloride causes metabolic acidosis, but gives me a normal gap. But from the venous chemistry, I see bicarb is down, gap is narrow, chloride is high, but bicarb is down. Patient has metabolic acidosis, partially induced by hyperchloremia. Okay, cool. So really, really important to just remember, right? pH, the higher your hydrogen, the lower the pH goes. That's that negative log scale. So I'm looking at hydrogen ion concentration. Normal concentration of hydrogen ion is 40 nanomoles. 40 nanomoles of hydrogen in the blood, that's the amount of acid in the blood, will confer a pH of 7.4. For every 10 of hydrogen that's increased, your pH will go down 0.1. Okay, every change factor of hydrogen by factor of 2 causes your pH to go down 0.3. So you're going to say to me, well, we don't really measure hydrogen ions. I don't care. You need to understand what the hydrogen ion is. Metabolic processes are always making acid. Acid attaches to negatively charged proteins like bicarb, like albumin. And this is absolutely essential to maintain that homeostatic pH through which we can actually activate our neurotransmitters, epinephrine, norepinephrine, for the myocardium and for the vasculature. So when we're out of homeostatic range, we can actually have a lot of problems. So we go back to what we talked about before. The higher the concentration of hydrogen, the lower the pH. And again, you can see right here, 7.4, 40 nanomoles of hydrogen. And as hydrogen goes down by 10, pH drops by 0.1. See? As it goes down, okay? As it goes up, I'm sorry, I said that very poorly. I'm so sorry. As hydrogen ion in the blood increases, the pH will go down. As hydrogen ion in the blood decreases, pH will go up. And we really look at it as a factor of 10, okay? So as a factor of 10. And only if this is causative. So not if it's a metabolic acidosis compensating for a respiratory alkalosis. You always need to know the primary problem. Now, I love this slide. I'm not going to talk about everything here. All I want you to note is that you've gotten a chemistry back. You have a patient who's a little unstable. They're not in an ICU. Nobody did a blood gas. You get a chemistry back and there's an anion gap. If you have an anion gap and it's wider than 16, 14 is the normal top range. But if your gap is wider than 16, you've got a metabolic acidosis. The end. Anion gap, you've got metabolic acidosis. You're going to try to figure out what that is. You're going to try to figure out what the issues are. You're going to look at whether or not our patient is compensating. And there are many other things that you can evaluate. But the most important perspective here is if there is an anion gap on your chemistry, you have metabolic acidosis. The next thing you look at is bicarbonate chloride, and then you do a blood gas. And it can be a venous sample. It doesn't have to be an arterial sample, because all you're looking for is the presence or absence of base in the blood gas. Base deficit, acid excess. Okay. So really important to remember that if I have a primary metabolic disorder, my patient is going to breathe fast, hard, and deep to blow off CO2 to try to get the pH back into a normal range, not to perfect, into a normal range. So 7.36, 7.37, so on, up to 7.4, which is perfect. And of course, with respiratory disorders, we're requiring metabolic confirmation to bring us back to compensation. So I love this slide because I think it makes things really simple, okay? Compensation is always in the same direction as the primary disorder. So if my bicarb is down and I have a primary metabolic acidosis, I'm going to compensate by blowing off CO2. If my respiratory system is hyperventilating and I have a primary respiratory alkalosis, my bicarb is going to go down, making my acid go up in order to compensate. And same thing is going to be true for respiratory acidosis. CO2 is up, bicarb's up for compensation. Metabolic alkalosis, bicarb's up, CO2 is up for compensation. So what's really important, and I think this is such a great slide, all three variables move in the same direction. Metabolic acidosis, okay? Metabolic acidosis, bicarb's down, CO2's down, pH is down. All three down, metabolic acidosis. CO2 is down because there's an attempt to compensate, but the problem is metabolic, which made the pH go down. That's how you know what the primary problem is, by the direction of the pH. Respiratory alkalosis, pH, CO2 is down, bicarb is down in order to retain more acid because your pH is on the alkaline side, your pH is up, and we're trying to bring it back to normal, and so on and so forth. but very straightforward because our focus today is metabolic acidosis. How do you use the anion gap and your blood gas and your base deficit to actually help drive therapeutic intervention? Really important here. Bicarb is down, gap is wide. Base is in deficit. Compensation is rapid breathing to blow off CO2, but the pH is less than perfect and may also be on the acid outside of range. So it could be in the range of normal, not perfect, but in the range of normal and be compensatory metabolic acidosis, or all the way outside of range, meaning less than 7.35, which is uncompensated. So metabolic acidosis, just like a boy band, everything moves in one direction. Look at those boys. They were really young. Now, we care a lot about this because one of the things that we chase that I am like so all over, and I'm really wanting to do some investigative research and some PI projects looking at this, we're so significantly chasing mean arterial pressure. But what we're not addressing is that in the presence of metabolic acidosis, we lose vascular tone. So we're adding more and more and more vasopressors. We're not improving perfusion. Lots of times we're not improving pressure. And the cycle just continues because I'm not really addressing the problem. The problem is persistent metabolic acidosis. Now, I need to return perfusion to normal to wash out lactic acid, to stop ketosis, to promote better kidney function. But I'm trying to do that by chasing the MAP with the vasopressor in a situation where my receptor sites cannot respond because of my acidotic pH. So really, really important to remember that one of the major things that happens primarily with metabolic acidosis, not respiratory, you decrease your responsiveness to catecholamines. So that means epinephrine, norepinephrine, not vasopressin. Vasopressin is not a catecholamine. But what we really see is that those patients are no longer responsive, and we're giving them super normal levels of catecholamines. They're on 20, 30, 40, 50 of norepinephrine, 5, 10, 15, I hope not, of epinephrine. We're doing massive neurotransmitter stimulation, but our patient is not responding. And that is a really important perspective. I want to remind you, you got to have a base deficit and a decreased bicarb plus an anion gap. If I cannot get a blood gas, I need my chemistry and I need to see an anion gap. So when the very first thing, when I've got a patient who's refractory to vasopressors, the first thing I want to know is, do they have metabolic acidosis? So I've got a blood gas, they've got a base deficit. I've got a serum chemistry, their serum CO2 is down, their gap is wide, they've got metabolic acidosis. Doc, I can continue to titrate up, but it's the metabolic acidosis that is making this worse. So we really have a couple of choices. The easiest one is bicarb. A little bit harder one is CRT, so I can start purifying your blood and clearing some of that metabolic acid out. But I got to do something. I can't spend 2 days titrating up, and now I'm at 150 of norepinephrine and 20 of epinephrine. Patient's still not responding. He's not going to survive. I've given him a bunch of volume. I'm making him worse because I'm not paying attention to the etiology of their severe widened anion gap and their base deficit. Happens every single day. Every single day in every single unit, doesn't matter where you are, doesn't matter what unit you're in, every single day, we can see patients who have increased production of hydrogen ion. They're in glycolysis, ketosis, they're in anaerobic metabolism because of poor blood flow. And if we add kidney dysfunction to that, then they're not excreting the metabolic acids. So that makes their metabolic acidosis even worse. So what we all always have to think about, always have to think about is what caused your metabolic acidosis. And I knew you had it because on chemistry, you had a wide gap. On chemistry, you had a low bicarb. If you have a low bicarb and a normal gap, most always because it's hyperchloremia, still acidosis, just don't have a gap. I have to be able to bring that to my provider. My patient has a normal gap because of hyperchloremia, but his bicarb is low and he's acidotic. I can't resuscitate his blood pressure, doc. He's got metabolic acidosis. Need a blood gas? Okay. On a blood gas, we look at bicarb, we look at base deficit. Bicarb's down, base is in deficit, metabolic acid is up. I have to do something. I can't continue to just stand by with patients who have significant, severe, profound, refractory metabolic acidosis, who are refractory to vasopressors, whose blood pressure cannot be controlled, and therefore blood flow dynamics are significantly altered. But it all comes back to the state of metabolic acidosis. And what can I do for that patient? Really, really important. Always important to remember, blood pressure down. If they got PA pressure, it's up. They're tachycardic, typically they're tachypneic. And when that occurs, always think metabolic acidosis, because metabolic acidosis promotes above and beyond everything else. What we have to think about is constriction of the arteries, constriction of the peripheral veins, constriction of the pulmonary arteries, and overall resistance to the administration of catecholamines. So that would be epinephrine and norepinephrine. Neosynephrine doesn't fall in the category here. Vasopressin doesn't fall in the category here. Angiotensin II or Giapreza doesn't fall in the category here, but the most common agents that you use at the bedside in resuscitation of pressure, norepinephrine and epinephrine. Really, really important. So again, in summary, metabolic acidosis is measured by buffers and base. Bicarb down, acid up. Base is in deficit, acid is up. Remember, it's because I'm making more acid and I might not be excreting them. I maybe lost a lot of bicarb, which also then will cause metabolic acidosis through diarrhea or through severe renal dysfunction or through polyuria. The buffer systems, that's bicarb, that's phosphate, that's albumin, magnesium, those actually take up the hydrogen. So providing that base neutralizes that strong acid. Okay, so really, really important. And also very important to remember the role of albumin here. Albumin is a significant buffer. Most critically ill patients have a very dramatic drop in their circulating albumin, which then can confer to a limitation in their buffer system and promote worsening metabolic acidosis. Always remember, base is 0 + 2, which is base excess, or -2, which is base deficit. A base deficit below -2 is conferring to you that your patient has metabolic acidosis. A base excess above +2, metabolic alkalosis. It's pretty straightforward. Base, bicarb, gap. Metabolic acidosis predicts mortality. And a wide anion gap predicts increased mortality. Metabolic acidosis in a critically ill adult is 2 times the mortality risk. And hyperchloremic acidosis is also associated with mortality. So from my point of view, the very start of any handoff is, what is your gap? What is your bicarb? What is your base? And what did I do about it? Because if I am not conferring these details in my handoff, I am participating in a failure to do the right thing for my patient. I always love to talk about base excess or deficit, just reminding us that a negative value, which is a deficit, means that I have excessive metabolic acid, and this is independent from PCO2. So, by the way, we might not measure hydrogen ion, but we assume it. We assume it by anion gap. We assume it by base deficit. We assume it by low bicarb. And what we want to remember is all of that is going to ultimately affect my pH. It also affects potassium regulation, potassium homeostasis. And without really good forward thinking, without just the first step, which is every time I hand off on a critical patient, I am going to know their bicarb, their base, and their gap. If I didn't have a blood gas, I'm going to know their bicarb, their gap, and their chloride. And I don't know how one can give a good handoff without actually including those items, because that becomes what we're going to resuscitate. I want to thank you very much for joining for today's Tuesday Topics, using base deficit, bicarb, and gap, driving therapeutic intervention. And the real truth of the matter is that if I can't clear metabolic acid, I must neutralize it. I can clear it by renal function, I can clear it by CRT, and I can neutralize it by bicarbonate. And only these are short-term solutions, because I've got to deal with the problem at hand. Are you hemorrhagic? Are you hypovolemic? Are you in cardiogenic shock? Are you in kidney shock? Got to deal with the state of your disorder. Are you ketotic and hyperglycemic? Are you ketotic and normal glycemic? I have to help control the problem. I know I've controlled the problem when the base comes back to normal, 0 plus or minus 2, when the gap is normal, and when my bicarb is normal. Once I get there, I typically don't have any problems maintaining blood pressure or organ function. So really important to remember in the progress of how we manage our patients and what we're trying to do for them, to actually enlist that role in your patient management. I want to thank you very much for joining today's Tuesday topic. I'm going to say goodbye for now, which basically means I'm going to stop my recording, and I hope to see you tomorrow. I hope to see you tomorrow where we talk about contractility. So thank you very, very much, and we'll see you.